Okay, thanks to Vishnu once again, and thanks to the IAN team for extending this invitation to me. And as in the previous session, as Vishnu was just mentioning, we listened to two excellent talks by Dr. Neeraj and Dr. Vishnu, who gave us an overview on the basics of peripheral neuropathy. So in this session, we'll be taking it one step forward. And in the first part of the session, you'll be listening to the immune-mediated neuropathies and how to approach these conditions. And the second session, you will probably be listening to Dr. Alexander Ross, who will be talking on the inherited neuropathy. So before I start, am I audible?
Yes.
So before I start, I would like to admit that this is a very vast topic. This in itself would require at least 4 sessions to complete its entirety. So this is a disclaimer. So I have tried to condense the topic into maybe like 30 to 40 minutes. So I'm not sure I'll be able to do complete justice to it, but I hope at least the junior members of the audience will have something to take home from this talk. So as always, we start by defining the problem. So how to define immune-mediated neuropathies? So unfortunately, there is no universally accepted definition for these conditions. So, but one good place to start would be to say that these are acquired neuropathies to start off, first of all, and are caused primarily by immune-mediated mechanisms. So here the operative word is primarily, because as if you would remember, Vishnu briefly touched upon last time, that even conditions like diabetes neuropathy has got autoimmune, immune mechanism, but obviously those conditions which have immune-mediated mechanism along with the primary pathology will not be in this group of conditions. So here we are dealing with a group of conditions where the mechanism is primarily immune-mediated. So these include a wide spectrum of conditions from acute to chronic, sensory to motor, distal to proximal, and everything in between. It's a very wide spectrum, and a number of conditions include under this rubric of immune-mediated neuropathy. In many cases, recently more and more antibodies and antigens are being detected, which is now found to be responsible for these conditions. But in all cases, a causative antibody or causative antigen have not yet been detected. Generally speaking, this group of conditions are eminently responsible to immune-modulated therapy, but as we'll soon see, this is not applicable to all conditions. In many conditions, unfortunately, we may end up with a really bad prognosis with nothing much to offer to the patient. So when we hear the term immune-mediated neuropathies, immediately few conditions jump into our mind. So these are the GB syndromes, which include the AIDP, Menon, AMSAN, the sensory, and so on and so forth. And the CIDP, along with its variants, which include the DADS, the MADSAM, the pure motor forms, and the paraproteinemic neuropathies, which includes the anti-MAC neuropathy, OMS, the CanoMAD, and the MMNCB. The systemic vasculitis and the neuropathies associated with these conditions, in fact, do form a part of immune-mediated neuropathy, but it's a huge topic to cover, and it's a huge session on itself. So I think we won't be discussing much about the systemic vasculitis and associated neuropathies. So where do we start? The whole the theater of this entire drama of immune-mediated neuropathy is actually set in the nodes and its associated paranodal area. So I think this is a good place to start. And we start by paying our tributes to Louis Antoine Ranvier, who initially described the nodes in the nerves. And if you take a close picture, let's see the axon and the myelin sheath and the Schwann cell up close and personal. So here we have the axon, innocent, helpless, and unprotected. And here we have the Schwann cell that approaches the axon and takes the axon in its arms and embraces it, sort of. And it doesn't stop there. It continues to throw its arms around the axon until the axon is completely covered in layers and layers of its folds. And a good analogy would be to compare a dosha or a chapati being rolled on layer after layer, and the gap between the gap between the two layers of dosha will be the extracellular space, and between the outer and inner layer would be the cytoplasm. So there are these alternate layers of membranes which are stacked one above the other. And as we can see, there are a number of proteins like myelin basic protein, myelin protein 0, and PNP22, etc., which are extremely important for maintaining this integrity. And I'm sure you're going to hear about these proteins in the next talk, so I'm not going to go about it further. So sticking with the node, so now this was axial section, and we can see this, the layers of myelin stacked on top of each other. And here, if we take a longitudinal section, and sort of here we have sort of unrolled the myelin, and here we can see, as Neeraj briefly touched upon in the previous talk. So at this point, the myelin is actually stacked closely on top of each other. It's called the compact myelin. And there will be certain lumps and bumps in between these myelin sheath. These are actually pockets of cytoplasm, what we call the Schmidt-Landermann cleft. But towards the end of these folds, the end of the myelin layer, I mean, towards the edge of the myelin fold, actually this myelin is thrown into these folds with these pockets of cytoplasm. So here we have the axon and the axolemma on the bottom, the Schwann's, the myelin sheath on the top, and towards the edge, the myelin folds with these pockets of cytoplasm are closely attached to the axolemma through these transverse bands. So if you take a higher power look, this is the cartoon which shows all these proteins and the structure of a peripheral axon and peripheral node. So basically the node is that part of the axon which is exposed to the extracellular fluid. So the main character or the main player in the node is, of course, the sodium channel. So the sodium channel has to be fixed in place, and is fixed in place by the ankyrin, which this is the bottom, below the bottom line is the axon, and above the line is the extracellular fluid. And the sodium is fixed in place by various proteins like ankyrin and spectrin to the axolemal side. At the same time, the sodium is also fixed to the Schwann cell microvilli by gliomidin and neurophasin 186, which are nothing but adhesion molecules. So there is a slight difference in the structure between a peripheral node and a node in the central nervous system. The main difference is that there is a Schwann cell microvilli in the case of the peripheral node, while in the central counterpart, we don't have this Schwann cell microvilli, but the basic structure remains the same in both the central as well as the peripheral nervous system. So here we have the sodium channel, which is anchored in place by the ankyrin as well as the neurophasin and gliomidin. And immediately adjacent to the node, we have the paranodal region, where, as we mentioned before, the myelin is thrown up into folds. And here the myelin throws out the important protein, which is called the neurophasin 155. And the axon at its end throws out the Casper contactin complex. And these two structures actually shake hands and form a very tight bond. So again, the structure and the architecture of the nodal and paranodal region is extremely important in maintaining the integrity of saltatory conduction. Why? We'll come to it shortly. So again, the main characters in the whole theater and the whole drama of immune-mediated neuropathy is the nodal sodium channel, which is located right here. And as I mentioned, it is anchored to the axonal cytoskeleton via the ankyrin, and onto the other side, to the Schwann cell microvilli by the neurophasin. Shown right here. At the paranode, we saw there is the N55 and the Casper contactin complex, which again gives a tight shake hand and forms a very tight barrier. So the basic essence is that the node and the juxtaparanode should be separate. So these should not come into contact between each other. And this neurophasin contactin Casper complex at the paranode makes sure that there's a tight barrier between the two compartments. Why is this important? This is because at the juxtaparanode, there is another front of sodium channel. Actually, we can't call it a friend, we can call it an enemy. Actually, the potassium channel is right here, the juxtaparanode. And it is held in place by the Casper, which it's anchored in place by the transient axonal glycoprotein. So these are the various proteins which are helpful in maintaining the entire structure of the node, paranodal, and juxtaparanode. And along with that, which is not shown in the cartoon, we have the gangliosides, which are present in the node and the paranodal region and juxtaparanodal region, as well as the myelin. So in addition to whatever we have discussed so far, there are various gangliosides which are present in the node, paranode, and juxtaparanode, which are all vital for maintaining the integrity of the whole structure. So in short, the ingredients for a healthy normal saltatory conduction is a high concentration of sodium channel, which is present in the node and exposed to the extracellular fluid. But on the other hand, we don't want the potassium to be exposed to the extracellular fluid, because that will result in hyperpolarization and will prevent a depolarization from happening. So these potassium channels for the moment are held, are secluded and segregated and held under the tight cover of the myelin sheath, which is fixed in place at the paranode by the NF55 contacting Casper complex. So that is why these two compartments should be separate. Potassium is well hidden and unexposed, while sodium is exposed to the extracellular fluid and helps and is important for the rapid depolarization and the saltate reconduction. So what goes wrong? When things go wrong, this nice, beautiful, well-oiled machinery and the architecture of the node and the paranode gets destroyed. A number of pathologies can make this happen. We'll take up these pathologies shortly. So basically, the tight attachment between the paranodal region gets loosened, and this myelin sort of slowly gets turned away or stripped away from the nodal region. In addition, the sodium channels are no longer anchored tightly, and this disrupts the normal functioning of the sodium channel, which again in turn prevents the membrane depolarization. In addition, the potassium channel now becomes exposed. This results in hyperpolarization, and in short, the whole process is thrown out of whack. And now the current, instead of passing over the myelin sheath, instead of jumping from one node to node, it actually passes underneath the myelin, and basically the saltate reconduction is no longer happening. So why is this? What sets this in motion? So we have heard about this mimicry from our BPS days. So there is basically there is some shared epitope between an antigen and between a foreign antigen and these various antigens expressed in the node and paranodal region. This foreign antigen could be a foreign infective organism like a Campylobacter jejuni or a viral protein from hepatitis or a Zika or even COVID. So there is some foreign antigen which shares some epitopes between those of the nodal, paranodal, and juxtaparanodal proteins, which trigger an inflammatory process in the periphery, and the blood nerve barrier is broken, and these inflammatory processes flow into the nodal paranodal region, which sets in motion all these inflammatory cascades, resulting in destruction of these nodal paranodal structures. So, this is what is happening in these various autoimmune-mediated conditions. For instance, in the Aman variant of GBS, the antibodies are directed against the various gangliosides. These gangliosides reside in the nodal and paranodal region. So obviously, destruction of these gangliosides result in eventual damage of the axons. So in the case of IADP, things are slightly different. Here, the antibodies are directed against the myelin sheath. Yet we don't exactly know which is the antigen against which these antibodies are directed against in the case of AADP, and to a certain extent in the case of CADP. So the pathology, there are some lacunae in our understanding of the pathology of AADP and CADP yet. In the case of CADP, we have recently, maybe in the past 5 years, 5 to 6 years, we have found a subgroup of CADP which behaves completely unusual to the normal course. It will be much more aggressive, which starts at a very young age, and there are a number of other systemic features as well. So these group of conditions, which are now called the neuropathies and the paraneuropathies, which have gained much attention in recent years, here the antibodies are directed at the various paranodal proteins. We have the adhesion molecules that we have seen, the Caspers and the contactins and the NF neurophasin. So these antibodies are directed to these antigens, the nodal and paranodal region, resulting in the disruption in the normal function. The pathology is almost the same in the case of MMNCB. The only difference being the antigen at the antibody here is IgM and is directed again at the ganglioside. So as we can see, the node, the paranode, and the juxtanodal region is the main place where all this pathology take place, and everything is happening. Most of the things are happening at the node paranodal region. That's why the whole structure is so much important. So this is where the antibody and the clinical phenotype matching comes to. So this list is quite familiar to most of us. So depending upon what antibody and what antigen the antibody is directed against, we have a host of conditions which can differ in the clinical phenotype. The most important and the most common among them is the GM1 and the GD1A seen in Aman and Amsan variant of GBS. GQ1B and GT1A, as we all know, directed against the midline seen in Miller-Fisher and the pharyngeal vertical variant, while the antibody is directed against the GM1 complex in the case of multifocal motor neuropathy, and the antibody is of IgM type, and so on and so forth. So once we have this covered, so with this background, let's try to design an approach into the various inherited neuropathy. So as Vishnu spoke about in detail about in the previous session, there are certain characteristics that we have to explore and concentrate on to finally get an answer to what we are dealing with. So let's start with the progression. So based on the onset and progression of symptoms, the disease can be called as acute if the progression is less than 4 weeks, chronic if the progression is beyond 8 weeks, and the gray zone in between is called a subacute. So mind you, I have to stress here that the catchphrase is actually progression. It's not the duration of the disease per se. Here, what we are looking for is the progression and the course of the disease. So if the patient reaches his or her mother within 4 weeks, it is an acute process. It doesn't matter if the disease extends beyond 4 weeks. Obviously, in the case of GBS or AIDP, patient continues to have symptoms well beyond 4 weeks. So that doesn't make it a chronic process. So here we are more interested in the course of the disease and the time from the onset to the zenith. And secondly, which system is involved in the sense that is it a pure motor syndrome? Is it a pure sensory syndrome, sensory motor, or is it an autonomic syndrome? So again, I have to give a word of caution here. There are very few things in neurology which are watertight, and same in the case of neuropathy as well. So though I say pure motor and pure sensory, there are only a handful of conditions which are really pure motor and pure sensory. There is usually a bit of an overlap. We can say a better term would be predominantly motor or a predominantly sensory. But there are a few conditions which are purely motor and purely sensory as well. But we will come to that later. So the third factor which we can sort of factor in to reach a definite diagnosis is the electrophysiological dysfunction. So as we all know, there can be demyelinating and axonal, but there is a third kind as well. I would like to touch upon it in the coming few slides. But before that, can it be normal? So of course, there are certain entities in the CIDP spectrum, the chronic immune spectrum, where the condition can apparently be normal. But another phenomenon, another factor is that the timing of the study. Suppose you do the study early in the disease course, of course, you may end up having a normal study because it takes at least 5 to 6 days for the findings to evolve. And the first change happens in the motor nerves, and followed by maybe 2 to 3 days, followed by the sensory nerves. So the timing is of utmost importance. So in day 2 or day 3, you may not find much of a nerve conduction changes. While if you do the study on a day 6 or day 7, you may end up by finding motor abnormalities without any sensory abnormalities, and you might localize it to a preganglionic or a radiculopathy, preganglionic lesion or a radiculopathy. But in fact, it's just a matter of timing. So the timing of the study is also extremely important. So there are certain other clinical factors also, which I am sure that Vishnu which Vishnu explained in detail last time as well. So specific to the scenario of immune-mediated neuropathy, we should focus on systemic features of vasculitis, which are umpteen in number. Probably you guys know much better than me. And there are we should also look for features of amyloidosis, which is an entity which is often not given due attention. And what about the course of the disease? So is it a resistant CIDP? Is it behaving like a normal CIDP? Is it anything out of the ordinary? Some systemic examination findings like an organomegaly or a bone pain. Are we dealing with a paraproteinemia or a POEM syndrome? Then is there any involvement of other systems? Like is there any tremor? Is there any ataxia? Is there any eye movement involvement, which is not that common in the case of chronic immune neuropathy? Probably we are dealing with a CanoMad or a CANDA. We'll briefly touch upon it later in the course. And what about again, is it an aggressive course? Is there any component of central nervous system as well? Because there are conditions where you can have central and peripheral demyelination, so-called nodopathy. So there are various factors that in the clinical examination and the general examination, which can give us a clue what kind of neuropathy we are dealing with. So again, with this template, we'll try to build a template which will help us, try to help us to cover the various immune-mediated neuropathy. So if a patient presents to you with the acute sensory motor syndrome, the first question that you have to ask yourself is, are we dealing with an LMN syndrome or a UMN syndrome? So never forget the fact that the patient can have an acute sensory motor or acute quadriparesis due to cervical myelopathy. Sometimes it is not that easy to differentiate between the two, but our job as a clinician is to first pinpoint where the site of location is. So if you are dealing with an LMN syndrome, then this flowchart is going to help us. So if you are dealing with an acute sensory motor syndrome, which is symmetric, it can either be a demyelinating or an axon unity. it is sometimes difficult to differentiate between a demyelinating and an axonal entity clinically, but Vishnu touched upon the clinical features which will help us in this distinction. But electrophysiology gives us the final clue. So if we are dealing with an acute sensorimotor symmetric demyelinating entity, and the weakness is predominantly proximal, so you are obviously dealing with an AADP. So we are all familiar with AADP, so there is no point in talking at great lengths about AADP. But just for completion, it's a motor sensory syndrome, and both proximal and distal muscles can be involved, but the brunt of the disease is usually caused by the proximal muscles. And bear in mind that the AADP can be predominantly motor syndrome. So patient may not even complain of sensory features initially, and it may be brought up only in examination. So it's a predominantly motor syndrome, and predominantly proximal muscles are involved, and cranial nerves are very frequently involved, and autonomic involvement is quite notorious, especially in the first few weeks. Another important point to note clinically is that the patient may complain of severe back pain, leg pain, or radicular pain, which may sometimes take us away from the correct localization. We may be misinterpret as it being a compressive myelopathy or even inflammatory myopathy, but it's not at all unusual for a GPS and an AADP variant to have a severe pain at the onset of disease. And when we interpret the test, we should always take into consideration the timing of the CS as well as the CSF. So let's go back to the flowchart again. So suppose on the other hand, so now we saw it's a demyelinating entity. For instance, what if it's an axonal syndrome? So the axonal syndrome, as we saw last time, it's again a length-dependent process, and the length-dependent sensory and motor syndrome would that be of AMSAN, where it's exactly almost similar to an AMAN, except the fact that the patient would have sensory symptoms or sensory findings, where you have at least two nerves showing abnormalities in snaps, where the snap amplitude is less than 50%. So otherwise, it almost resembles an AMSAN, like a length-dependent process from distal to proximal, and the reflex can be absent in the area of involvement. So on the other hand, suppose if you are dealing with this acute sensorimotor syndrome, which has an asymmetric presentation, and if it is a demyelinating entity, bear in mind that sometimes the CIDP variants such as focal CIDP or a MADSAM can also present acutely. For instance, like a brachial plexitis or a focal neuropathy can, especially if they are recurrent, always think of the possibility of a focal CIDP or a MADSAM, which can also present in the acute stage. On the other extent, if it is a sensorimotor syndrome, which is asymmetric and axonal, things are quite easy and straightforward. We are dealing with the mononeuritis multiplex, and it's the peripheral counterpart of the stroke. It's basically a nerve stroke. As we know, the most common condition causing mononeuritis multiplex is obviously vasculitis, but we'll not be dealing much about this part now. So now let's moving on. We saw the sensory motor syndrome. Now let's see the predominantly motor syndrome. So if it's a pure motor or a predominantly motor syndrome, which is symmetric, and if it is demyelinating, as I mentioned, AADP is hardly pure motor. So I don't want people to mistake this, but presentation can be sometimes as a predominantly motor, but the sensory findings can only be in the background. So it is very easy to mistake the presentation, especially in the first 2 days, as a channelopathy or an inflammatory myopathy or even a myasthenia gravis. So AADP should be in the differential, even if the sensory symptoms are not there in the forefront. That is all what I want to highlight. But otherwise, a pure motor symmetrical syndrome, if it is axonal, the diagnosis is AMAN. So AMAN again is a symmetric progressing predominantly. It's a purely motor entity, and in the site of involvement there can be areflexia, but hyperreflexia is seen in as many as 10% of the patients. The exact pathology still remains unclear. One postulate is that the antibodies are directed against the internode at the spinal cord, probably that is resulting in a supraspinal inhibition. That is one postulate, but we yet don't know exactly what the cause is. The autonomic dysfunctions are comparatively less compared to AADP, and the NCS obviously shows some axonal feature without any demyelination. This is as per the standard literature, but is it really so? So I would like to stick on to this topic. AMAN is a very interesting phenomenon. So just to take you a bit more into the entity of AMAN. So initially when GBS was described, maybe the early 1900s, there was only one single entity that was thought to be there, that is the AADP. But by and by, people started reporting this unusual phenomenon of acute motor severe paralysis initially in the Northeast Chinese and also in the Mexican population, where children, there seems to be a pandemic of this acute flaccid paralysis following infection following a diarrhea infection. So then we became aware of this entity where it's a predominantly axonal problem, where the antibodies affect the axon and leaves the myelin apart. So that is how the entity of Aman and the AMSAN came to be detected and came to be noticed. So among the various infective agents, the Campylobacter jejuni, now we know, is clearly associated with with Aman, and usually can have a bad prognosis. As per the various scores like MEGO scores, they factor in the presence of diarrhea to prognosticate the patient's condition. So Campylobacter jejuni definitely has got a pathological role, but a given patient can have, given a patient who was exposed to Campylobacter jejuni can end up having an Aman, or could also end up having the Miller-Fisher syndrome. So how come this dichotomy is happening? So suppose if you are lucky enough to have, this is purely based on what kind of serovar or what kind of variant of Campylobacter jejuni you are infected with. Suppose if you are unfortunate enough to be exposed to the variant which expresses GM1 or GD1A like lipooligosaccharides on its cell surface, obviously the body will be producing antibodies against the GM1 and GD1A, and where the brunt of that itself will be on the roots and the nerve terminal, and you end up having an Aman. But on the other hand, if you're fortunate enough, so to speak, to be infected by the organism which expresses GT1A and GD1C on its cell surface, the antibodies are mainly directed at GQ1B or GT1A, and the antibodies are mainly attacking the oculomotor nucleus and the muscle spindle, and you end up having the Miller-Fisher syndrome. So this sort of interesting diversity is seen within the Aman. So that is the reason why we have a whole spectrum of condition, and how this basically what kind of antibody and what kind of antigen is involved sort of determines the phenotype. So another interesting scenario is that we have all seen that certain patients with Aman recover rapidly, while others go on to fare poorly. And why is this so? So we all know about the two different electrophysiological dysfunction. One is the demyelination, which is due to the damage to the myelin sheath, and while on the other hand is the axonal pattern where the damage is in the axons. But a third type of conduction abnormality also has been well established now, and this is what we call the reversible conduction failure. This is simply because the antibodies, as we saw, would mainly cause havoc at the nodal and paranodal region. So the node, as we know, are the sodium channels, and the brunt of the attack is borne by the node, and the sodium channel is completely wrecked. And this results in an apparent conduction block without any demyelinating feature. So here in this condition, we have conduction blocks without any temporal dispersion. So this is what we call reversible conduction failure, and this is the reason why we have two different outcomes for Aman. On one side, so again coming back to the our favorite diagram now. So we have the node where the sodium channels are located, and the paranodal and juxtaparanodal region, and everything is hunky-dory and everything is nice and smooth. But when we have an attack, this whole structure is thrown out of the normal architecture is lost, and now we have no longer the normal saltatory conduction. This is what we call the reversible conduction failure, and it's also sometimes referred to the axonal conduction block. From this point, there can be two possible outcomes. One, this is a highly unstable state. From this, the nerves can rapidly undergo axonal regeneration, and the axons can die off, resulting in the true Aman, and where the patient finally ends up having a very poor prognosis. On the other hand, if there is the appropriate intervention, either in the form of treatment or by the body's own mechanism, if somehow the insult is stopped at this stage, the nodes can sort of regenerate and recover on its own and sort of remyelinate, and the sodium channels are re-established, resulting in a rather rapid improvement. So this is the whole reason why we have two different outcomes for Aman. And interestingly, previously thought the conduction block is not seen only in AADP. So if you see a conduction block, do not always consider it demyelination alone. It could be a reversible conduction failure. And similarly, if this phenomenon occurs beyond the distalmost point of stimulation, you can end up having an absent CMAP. So you may think if the patient is having an AMAN, you may think the patient is going to have a poor outcome, but this is a reversible conduction failure, and the patient actually can have an excellent outcome if appropriately treated. So at this point, I'd just like to touch upon the treatment-related GBS-TRF, the term called the GBS-TRF, which is the treatment-related fluctuation, where the patient can have an initial period of improvement and stabilization, but it is followed usually by a course of worsening in the next 2 months. And the only thing that we have to do at this juncture is to treat the patient again with the initial course to which the patient had a favorable outcome, like either IVIG or plasma exchange can be reinstituted. This is thought to be due to a re-establishment of the antibody population. But if you have a three or more treatment fluctuation, the patient is considered to be CIDP and has to be treated as a CIDP. So going back to our, let's see the time. Going back to our chart and sticking on to it. So now we have seen the acute sensory motor. Now we know the acute pure motor, and let's see the pure sensory. So this is slightly tricky. So we can have a pure sensory variant of GBS. So the pathology is thought to be demyelination. So but it's difficult to exactly pinpoint a demyelinating pathology in the sensory nerves. If we can have some evidence of demyelination in motor nerves, but the patient is having purely sensory findings, probably you can call it a pure sensory GBS, but a very close differential. Most often in pure sensory GBS, the snaps may be absent. So in this situation, it can very well be an acute ganglionopathy or a sensory neuronopathy where the damage is the dorsal root ganglion, and you get a diffuse loss of sensation. So a patient presenting with the pure sensory symptom, which is symmetric, can either be pure sensory GBS or an acute ganglionopathy. The only thing in ganglionopathy is the symptoms and signs may not be that symmetric. And there are certain findings in the pathology, like for instance, like S100. Anyway, there are some pathological differences which can help us to differentiate between pure sensory GBS and acute ganglionopathy. But this entity is relatively very rare. So now, after finishing up the acute entities, let's graduate to the chronic entities. So in the same pattern, let's take into consideration a chronic sensorimotor syndrome, which is symmetric in onset. So now we have three electrophysiological patterns. If it's a demyelinating, it's definitely a CIDP. And it's basically, you can call it a counterpart of the AIDP, but there are certain differences. Here again, it's predominantly a proximal involvement, though proximal and distal can be involved, but again, it tends to be more of a proximal motor weakness. Here also, it's a sensory and motor syndrome, sensory signs and symptoms can also be there, but it may not be too surprised if the sensory symptom is not that much in the forefront. Again, there will be pan-areflexia, but the autonomic findings are much less common, and the cranials are much less common, provided you are dealing with the typical CIDP. There are NDCGTs where you can have a significant autonomic and cranial involvement, but we will come to that later. But in the case of typical CIDP, this is the picture. Here again, this is CIDP is one condition where the attack does not occur at the nodes. It's mostly at the paranode and internode. So maybe you can call it an internodopathy. So now we are all interested in nodopathies and paranodopathies. Probably CIDP, we can call it as an internodopathy because the antibodies bind to hitherto unidentified antigens at the internodal myelin. So once the antibodies bind, either through membrane attack complex or through macrophages, the myelin gets slowly stripped off the axon again, leaving it naked, resulting in the entire pathological process. Now, let's see the other pattern. So suppose a patient comes to you with a CIDP-like picture, and you do the conduction, and to your surprise, you find the conduction is completely normal. So here, except for the fact that probably the FFs are abnormal. So here, everything is looking like a CIDP. The MRI can show enlarged roots. CSF can show adenocytologic dissociation, but the conduction is fairly normal, except for maybe the mild drop in FFs. The only difference is that the CISMP, this is a recently explained entity. It's called the chronic inflammatory sensory motor polyneuropathy, where the site of involvement is the only difference is the site of involvement is more proximal. It's close to the roots and before the dorsal root ganglion, and that's the reason the snaps are normal. And that's the reason they face are only abnormality. So when you have a CIDP like presentation, but the conduction is mostly normal, think of this entity. So then if it's a symmetric sensory motor axonal process, vasculitis, around 30 to 40% of cases can present as a clearly exactly like a peripheral neuropathy. So mononucleus multiplex is not the only presentation of a vasculitic neuropathy. It can also present as a length-dependent sensory motor neuropathy as well. So there is another entity called chronic immune-mediated axonal polyneuropathy, which also can have a sensory motor distal axonal presentation. We'll see to it in the coming slides. So on the other hand, if it's an asymmetric demyelinating process, so we already touched upon MADSAM. So basically, you can call it a demyelinating mononucleus multiplex. Basically, it's the same as mononucleus multiplex. The only difference is that the pathology is demyelinating. It can pick and choose various nerves randomly. It usually starts in the upper limb, but unlike the mononucleus multiplex of vasculitis, there won't be any pain. And focal CIDP is a very rare entity. But when a patient presents to you with recurrent site-restricted nerve involvement, like recurrent brachial plexitis or recurrent Parsonage Turner or a recurrent anterolateral nerve or musculocutaneous nerve palsy, think of a possible immune-mediated process like a focal CIDP. So the sensory motor asymmetric axonal, as we already know, is a mononucleus multiplex. So moving along, so let's come to the pure sensory chronic form. So if it's a symmetric entity and it's demyelinating, it can be DATS. The asterisk means that again, DATS is not purely sensory. There will be an element of motor, but again here the sensory will predominate. So let's have a quick look at the DATS variant. It's also called the distal CIDP or distal acquired demyelinating symmetric neuropathy. It is the prototype of the entity is like a 50 to 60-year-old gentleman presenting to you with a very slowly progressive illness lasting for a period of 5 to 6 years, where it starts with the paresthesia and numbness of the feet, which slowly ascends up. Slowly his gait starts getting affected. He feels a lot of imbalance. He'll have a lot of upper limb tremor. So this is the typical presentation of DATS. You can have a bit of a distal weakness, but weakness is never in the forefront. And the conduction, the classical finding is said to be the terminal latency index, where basically what it denotes to is that the pathology is mostly distal, unlike a CIDP where the pathology is mostly proximal in the roots and mostly in the roots and the large nerves. Here the pathology is mostly the distal part of the nerve. So there is an association with paraproteinemia. And based on this association, the entity of DATS can be divided into DATS-I and DATS-M. DATS-I referring to the idiopathic variant, while the DATS-M is the one associated with the paraproteinemia. So DATS-I is exactly the same as a CIDP. It's really a variant, it's a genuine variant of CIDP and can be treated exactly as a CIDP. While DATS-M, that association is with IgM paraproteinemia, and around 70% of patients with DATS-M have the MAG neuropathy. So there's a bit of an overlap. Some authorities refer to it as an anti-MAG neuropathy, but in all cases of DATS, the anti-MAG need not be positive, and the anti-MAG neuropathy can sometimes present the different phenotype other than DATS as well. So there's a bit of overlap, but these are not exactly the same. There are some mild differences. So basically, these are paraproteinemia associated neuropathies, and the important clinical significance is that the response to treatment is not as good as in a standard CIDP, and you may have to hit the disease hard with rituximab early in the disease itself. So if it's a pure sensory symmetric and a so-called axonal picture, where the snaps are absent, you could be really dealing with the ganglionopathy. So if on the other hand, if it's a purely sensory syndrome and you have the conduction as normal, in such a situation, you will always have to think of a localization proximal to the ganglion. It could be in the roots, it could even be in the posterior column. So we have to think of a lesion proximal to the ganglion. So since we are dealing with a neuropathy, if the snaps are normal, the lesion is located proximal to the ganglion, and here we are dealing with what we call the CISP or CISP. It's a pure sensory syndrome, progressive pure sensory syndrome from distal to proximal. It's sometimes called the pure sensory variant of CIDP, but again the NCC is normal. But one clue is that SSCP is abnormal. This means the lesion is proximal to the dorsal root ganglion. MRI will show thickened roots and the CSF protein can be elevated. And lately, there are a number of variation in this theme, a number of entities with this variation, this basic theme has been described. In the case of a pure cyst, the lesion is in the dorsal root ganglion. And they have also been this cyst plus also described as every combination, every permutation combination has been described. So where the disease also sort of like licks the dorsal root ganglion and the spinal nerves without really biting them. And so here we have a picture which clearly shows so when there's a lesion proximal to the dorsal root ganglion is confined to the dorsal root, this region alone, we end up having a cyst. When there's involvement of the proximal roots of sensory and motor, we end up having a CASMP. And when the lesion is there in the proximal as well as the distal entity, or that's what we call the chronic inflammatory demyelinating polyradiculoneuropathy. So this sort of covers the entire spectrum of. Its only difference is that where the disease is located, where the pathology is located. So. Finally, we come to the pure motor form. If it's a pure motor symmetric form, and it's a demyelinating, the pathology is demyelinating, we call it the pure motor CIDP. And then there is also the CIAP, where the disease is again a chronic axonal process. It's progressing beyond 2 months. So one thing I would like to point out, CIAP is sometimes an acronym that is used for chronic idiopathic axonal neuropathy. So this has to be differentiated here. The I stands for inflammatory and the IR stands for immune responsive. So when we have in any center, around 30 to 40% of conditions remain undiagnosed. Axonal neuropathy remains undiagnosed. That is what we call the chronic idiopathic axonal neuropathy. But here things are different. This is eminently treatable and treatment responsive. This is having an inflammatory component. This is shown by the fact that the CSF protein is high, and the biopsy also shows a clearly inflammatory component. So this is how we differentiate from as chronic idiopathic, and this is a chronic inflammatory entity as evidenced by the high CSF protein and the treatment responsiveness. So if we are dealing with an asymmetric demyelinating entity, we obviously know it's an MMNCB. So MMNCB is a very interesting condition where the presentation can be either a stepwise or a gradually progressive. It's one of the rare conditions which are purely motor. There would not be any sensory. Maybe the patient can report some vague sensory symptoms, but there won't be any sensory signs. There should not be any sensory signs to call it an MMNCB. It can sometimes mimic motor neuron disease. So all the tests that we do for a patient presenting with MND is to try to find out if the patient is having MMNCB, because this is treatable, while in another case, unfortunately, there is not much treatment. So our job is to try to find out if a patient presents the purely motor syndrome, asymmetric pure motor syndrome, which mimics like a motor neuron disease. It's one of our investigation is directed to find out if the patient is having MMNCB and not motor neuron disease. Again, the diagnostic hallmarks, the demyelination with conduction block, but MMNCB can also occur without the CB, can occur without the conduction block, and clinically it behaves almost the same as those with CB. So MMNCB and MMN without CB is almost the same. The treatment and the clinical response is usually the same. Here the antibody is against the IgM antibody against the ganglioside antibody. So ganglioside antigen, again at the node and the paranode. And here the treatment is by IVIG. So steroid and even plasma exchange may not be beneficial. So IVIG and cyclophosphamide would be the mainstay of treatment. And there is also this condition called multifocal axonal motor neuropathy. So you can sort of like, instead of conduction block or demyelinating feature, you can have a predominantly axonal feature. So as the disease goes on, the MMNCB itself can have an axonal feature in the future. So that they sort of mimic an MND. But to start off, also sometimes we can have this sometimes called MAMA. In that case, it is usually responsive to steroids. So it's not possible for us to cover the entire points in treatment. So some highlights I would like to just stress upon. Generally speaking, CIDP and its variants have good response to steroid and the first-line treatment, but the variants are usually not as responsive as CIDP. And in pure motor CIDP, steroids are not preferred, IVIG is preferred. In the case of MMNCB, as I mentioned, it's IVIG or cyclophosphamide, that's the main line of treatment. And the DATs or the anti-MAC, the rituximab is the main line of treatment. Again, the neuropathy and paraneuropathy, again, rituximab is the first line of treatment. So one point to note, whenever there is treatment resistance, whenever the patient is behaving in the course of the illness is not like what we expect in the routine CIDP, take a moment to think about the diagnosis. Maybe we are dealing with something different. So whenever we have a resistant CIDP, think of a Cohen syndrome or a neuropathy or a paraneuropathy, or probably an amyloidosis setting in, or even think of CMT, especially in young children. So with that, I'll introduce the term the neuropathy and paraneuropathy, which has become popular in the past few years. So as we saw already, everything happens at the node, paranode, juxtaposed paranode. So there is no fun in calling a special term like paraneuropathy and neuropathy because everything happens there only. But it's a good way to classify based on the site of action of the antibodies. So there can be neuropathies with antibodies at NF186, which is the node that we saw, which helps to fix the sodium channel, and paraneuropathies with antibodies to NF55 and the conductin. And even AMAN can be called a paraneuropathy, in fact, because the antibodies to ganglioside again attacks the node and the paraneuropathy. So even AMAN can be a neuropathy or a paraneuropathy. And then there's juxtaparaneuropathy where the antibodies are directed against Caspar-2. So Vishnu, please let me know when I have to stop. When I'm overshooting time, please let me know.
No, Deepak, you can take some time because the other lecture is a recorded lecture. So we have time. You can have a buffer of 10-15 minutes.
Okay. Please let me know when the time is up. Okay. So basically, the clinical significance of this neuropathy, paraneuropathy is that it was initially described in a subset of patients with CIDP, which was behaving almost unlike a CIDP. So that in the sense that these patients had a very young age of onset, and it was a very aggressive course with rapid progression, and the patients had all this tremor and ataxia. And so this set things in motion, and further evaluation found that in these patients, unlike the CIDP, there were these antibodies directed at the nodal and paranodal region. So these are no longer called CIDPs. These are actually a separate entity from CIDP. The pathology is again demyelination, with the brunt of the insult occurring at the nodal and paranodal region. But eventually, this is a very unstable state, as we saw earlier. Just like AMAN, this can progress to axonal degeneration, and hence this is the reason patients usually have a poor prognosis. So this is a figure which we are now all of us are now familiar with. So on the left side is the healthy structure where we have the various proteins at the node, the paranode, and the juxtaparanode. And these antibodies, in fact, attack these the Caspars and the contactins in NF, resulting in alteration of the morphology and which manifests as the neuropathy and paraneuropathy. So the clinical, talking about the clinical picture of these conditions, the anti-neuropathy taken as a group, all of them are aggressive and rapidly progressive, but neuropathy tends to affect the younger population. Again, none of this is watertight, none of this is black and white. Now, all of the conditions that we have discussed so far, please bear in mind these are not discussed. If a given patient does not follow the textbook pattern, there will be a lot of overlap between the conditions, and things are not as easy as it sounds to differentiate between the entities. So coming back to neuropathy, it's an aggressive and rapidly progressive disorder. Sometimes it can present as a GBS, like an acute CIDP or a GBS-like presentation with all of autonomic and cranial affections. There can be involvement of tremor, ataxia, and nephrotic syndrome. But bear in mind that these proteins are present, these attention molecules are present in the axon, in the central nervous system as well. So probably that's the reason why they have these central and peripheral manifestations. But why these patients have nephrotic syndrome, I have no idea. So there is this so-called CCPD, which is the combined central and peripheral demyelination. And all of these entities are poorly responsive to the first-line agents. And rituximab has to be initiated early in the course. So that is probably one reason probably the clinical significance of these entities. We need to pick up these entities early in the course so that we can start treatment much more early, so that we can sort of arrest the progression of the disease. So contactin Casparon complex, again, we saw that these complexes are in the paranodal region. It's slightly older age group, and the ataxia is more prominent. And Caspar-2 is actually the prototype of the hyperexcitability syndrome, where the patient can have the muscle stiffness, clinical and electrophysiological myokemia, and also autonomic symptoms. It's usually a painful neuropathy, and there can be an association of thymoma. So these are the red flags. So when you encounter a patient with CIDP, If you find any of these features, then your guard has to be up. Maybe you're dealing with something other than CADP. So if it's an aggressive course, a young age of onset, predominantly motor with early cranial nerves and nephrotic syndrome, think of the NF and the conductins. A pure IVIG responsiveness in a patient with CADP, always suspect a nodopathy or a POEMS or an amyloidosis or a MAC or even a CMT, which can actually, probably the next speaker is going to touch upon this. Sometimes CMT and immediate neuropathy can sometimes be quite difficult to differentiate. So always think of a CMT even when the patient is not responding the way you want him to respond. And when there's a peripheral and central demyelination, we are dealing with an anti-NF one. When the tremor and the attacks is out of proportion to the sensory symptoms. So think of a cerebellar involvement where, again, the anti-NF ones and the dialoso-acyl antibodies, again, the canomats and the CANTA comes in. When there's an intense neuropathic pain, think of an anti-Casper syndrome or even an amyloidosis, where the patient can have intense neuropathic pain. So this brings us to the last portion of the talk, which is the paraproteinemic neuropathy. Paraprotein, as we all know, is an abnormal immunoglobulin or a fragment of the immunoglobulin, which is produced by the abnormal clonal proliferation of plasma cells. So in a paraproteinemic neuropathy, to put it across very briefly, there can be three types of presentation. Number one is the DADS variant, where it's usually seen in IgM paraproteinemia, where this picture shows that the anti-MAC neuropathy or the DADS variant, where this the previously compact myelin is no longer compact, it sort of gets swollen up and sort of spreads out. This is the electron microscopic view of a patient with anti-MAC neuropathy. Second is a CADP-like picture where we have the POEMS syndrome. And third is the axonal sensorimotor neuropathy, which you see in the non-IgM paraproteinemias and also in amyloidosis. So these are basically three kinds of presentation. And as we know, this sort of shows us the overview of the entire spectrum of the paraproteinemias. So at the benign most end of the spectrum, we have the MGUS, where the plasma in the bone marrow plasma cell will be less than 10%. The M protein will be less than 3 milligram per deciliter or 30 gram per liter, and there is no involvement of organ damage or the CRAB symptoms. There is no hypercalcemia, there is no renal involvement, there is no anemia or bone involvement. So the next end of the spectrum will be after MGUS will be the smoldering myeloma, where we have more than 10% plasma cells, and you have an M protein which is more than 3 gram per liter, but there is so far no organ damage or symptoms. Then we proceed to the realm of the multiple myeloma, which have all the three. And at the other end of the spectrum, similarly, we have the Waldenstrom's macroglobulinemia, where the paraprotein is usually IgM. And we also have amyloidosis. Sometimes we often forget that amyloidosis is a plasma cell dyscrasia. And we also have the POEMS syndrome. So the importance of the neurologist is that actually MGUS is very common, like can be seen in like 5 to 7% of aging population. So it does not have any clinical IgM. MGUS on its own would not have any clinical feature. It may be picked up on protein, serum protein electrophoresis. But for us, it's significant because there is this association with DADS, the DADS-M, and anti-MAC can be seen in like 50% of population, 50% of patients with DADS-M. And sometimes it can progress to such an extent that it can get really troublesome, and there it will warrant treatment with rituximab. The non-IgM, that is IgG or IgA MGUS, is probably the most common form of MGUS, but it's usually the association with neuropathy has not been well defined. Probably it's most likely a chance association, and we don't yet know that these are associated with CADP. So if in a patient of CADP, you do the electrophoresis and you find the IgG or IgA, the treatment is exactly the same. Obviously, the patient has to be followed up for the MGUS, but it doesn't mean that the IgG or IgA is causing the CADP. So there is no real causal association with the G and IgA paraproteinemia, unlike IgM. So Waldenström macroglobulinemia, another paraproteinemia where you can have hyperviscosity syndrome, lymphadenopathy, organomegaly, fatigue, and so on and so forth. It's usually again IgM paraproteinemia, and this is almost same as the like a person's like a demyelinating entity. In the case of POEMS, all of us know about POEMS. We have this multi-organ involvement. Here the paraprotein is maybe IgG or IgA, and it's almost exclusively lambda light chain. It can be demyelinating. It is demyelinating, but later on the axonal pattern can set in. And the treatment also depends upon the kind of plasmacytoma. If there are, if the bone marrow shows plasma cells, or if there are 3 or more lytic lesions, you have to go for a systemic treatment. If not, you can also opt for a local radiotherapy, local treatment. And primary amyloidosis, The presentation is like an axonal neuropathy, and it's an early bilateral CTS and autonomic features. And if you have any M protein with any evidence of any other end organ damage, think of an amyloidosis. Also, what is hematological significance? We should bear in mind that it's not enough to make a diagnosis of MGUS and sit on it. So the yearly rate of conversion to multiple myeloma is around 1%. It seems to be a very small number, but it's something to be monitored. While in the case of smoldering multiple myeloma, the risk is like 10% the first 5 years, and after that the risk drops. So what are the risk factors which predict a progression for multiple myeloma? One is a non-IgG paraprotein. If you do a electrophoresis and the immunophysician electrophoresis, and if you find an IgG, it's the chance of it progressing is less. While if it's a non-IgG, chance of it progressing to myeloma is more. If the M protein quantity is more than 1.5 milligram per deciliter or 15 gram per liter, and if there's an abnormal free light chain ratio, there is a ratio between the kappa and the lambda is less than 0.26 or more than 1.65. So these are the factors which would predict the progression for the MGUS to myeloma, and we have been more aware. So if the patient can be monitored 6 monthly with M protein levels, the free light chain, and if the levels are showing a trending pattern, probably it's maybe a good idea to refer the patient for hematologist. The threshold for referral can be low. We also have to keep on inquiring for any CRAB symptoms or any systemic symptoms. And if there is any suspicion, it would be a good idea to get a whole body MRI or to the bone marrow, or even better, refer to a hematologist. So what are the tests that you want to do? So basically there are 3 tests that you can do. One is a serum protein electrophoresis. So here the thing is that we can quantify we know that we can find that there is an abnormal M protein, and probably we can also quantify the level, like whether it's like more than 3 gram per deciliter or whatever. We can actually quantify the level of M protein, but we don't know what M protein, what is the paraprotein that is abnormal. And also in 25% of patients, even with myeloma, this SPEP may be spuriously normal. So that is the reason we need to always follow it up, or always combine the serum immunoelectrophoresis or serum immunofixation electrophoresis. Both are seen. And this actually can identify the kind of monoclonal protein involved. Whether it's an IgG, whether it's a kappa or lambda, or that kind of information you can get from the serum immunofixation electrophoresis. Sometimes they also give the level based on the electrophoretic pattern, but I'm not sure it's very trustworthy. Maybe it will be an underestimation. If you do an immunoglobulin level estimation, that will give a better picture, but it's not usually warranted to screen with the immunoglobulin level. So combination of SPEP and SIEP would give us a good picture. And if you combine that with the free light chain assay or the kappa lambda ratio of the free light chain assay, that will be an excellent screening tool with the high sensitivity to specificity for all kind of paraproteinemia. But I think it's slightly expensive in our setting, but this is the standard guideline. And serum is as good as urine. The only urine can be slightly cumbersome because 24-hour urine sample is sometimes suggested. So serum should do quite fine. So the POEM syndrome, that itself can be a topic for a discussion. So there are various criteria that have been evolving over the years. It's a predominantly demyelinating entity and can have this multiple multi-organ dysfunction, ranging from all these skin lesions to endocrinopathy. And this is a very interesting entity where you have the chronic ataxic neuropathy, where you have the canomad and the candac. That is, canomad is the chronic ataxic neuropathy with the subthalanoplagia, M protein, cold agglutinin, and diacylose-acyl antibody. So this is nothing but it shows that the ganglioside against which the antibody is directed has 2 sialic acid. So the D stands for the number of sialic acid. If there are that GD and GT and GQ just shows the number of sialic acid. 1 stands for the order of migration, and A for the position of the diacylsialic acid. If it's outer, it's called A, and it's called M. It's called B. So in this spectrum of canomad, the antibodies directed against the ganglioside, which has 2 sialic acid residues. So that is what we call the diacylose antibody. The presentation in brief can be exactly like a chronic variant of MFS. That's the easiest way to put it. So Miller-Fisher syndrome presenting over a matter of many months is something that is, when you see that happening, you suspect a canomad. The NCS is usually a mixed pattern. The MRI is normal, letting us know that there is no brainstem or cerebellar involvement. Usual paraproteinemia is IgM, and patient, if treatment is required, responds favorably to IVIG and rituximab. And last, but not the least, we should also remember that amyloidosis is a plasma cell dysplasia. Exactly the same pathophysiology which takes you down the route of a myeloma can also occur with amyloidosis, because these immunoglobulins can deposit in various tissues and become abnormally beta plated and end up being amyloidosis, end up having amyloidosis. Here, unlike the other entities that we saw so far, it's an axonal neuropathy. The patient can have a painful sensory syndrome, painful sensory motor axonal neuropathy with early CTS and autonomic symptoms. There will be evidence of plasma cell proliferation in the form of SPEP and SIP abnormality, and there will be other endorphin. So it's always important to look for any other involvement. So there's a significant loss of weight, prominent GI symptoms, cardiac symptoms, renal involvement, periorbital ecchymosis, macroglossia, shoulder fat pad sign, etc. These are all features to show that there is a primary amyloidosis at play. So final confirmation is by doing a tissue biopsy, either the nerve or the fat pad biopsy, where you can show a congruent state. So with this, I would like to stop and end right here. So I have tried to take you through the entire gamut of autoimmune neuropathy. I've slightly exceeded the time, sorry for that. So we have the acute, we saw this acute, the chronic, the nodopathy, the paranodopathy, the various antibodies that are involved. And so bear in mind, it has a wide spectrum of conditions. It can have range anything from acute to chronic and sensory to motor or any presentation. So the importance is these entities mostly are clearly treatable. So picking up this early in the disease course may help our patients a lot. So I'll stop with this now, and Vishnu can take over. Happy Onam to all of you.
Thank you, Deepak.
At the outset, I'm extremely sorry. I joined late. I was held up somewhere. I'm extremely sorry for it. Phone is not with me, so I could not. Sorry, extremely sorry.
No issue. So with that, the Deepak had extensively covered the immune-mediated neuropathies. We have a lot of questions. So since the next talk is a recorded lecture of around half an hour, 35 minutes, we have some time to cover. So I'll just take up one question, one by one, all the questions. So the first question is, what is the importance of antibody typing in immune-mediated neuropathy from the treatment point of view? So if you think that as an identifying any particular antibodies, probably how do you think the treatment will change?
An excellent question. Excellent question. So in routine clinical practice, there is no reason for you to routinely do these antibodies if you are sure about the diagnosis. So the only thing the antibodies helps you is that it gives you another layer in the diagnosis. For instance, it's not always easy in clinical practice to, sometimes it's not, our presence will agree with me. Sometimes it's not even easy to make a diagnosis of GBS. In those cases, these ganglioside antibodies may help. Otherwise, it does not have any bearing on prognosis. It does not involve the management in any way. So only thing is that it gives you an assurance or give you another layer of diagnosis and we are sure that we are dealing with the GBS. That's the only advantage. A good question.
Okay, Deepak, for example, if a GBS patient progresses rapidly within 24 hours, goes into a ventilator, it's a little unusual for a normal GBS to that it happen everything or will you consider a paranodopathy that you were discussing when you were discussing paranodopathies, you were telling about neuropathies, we can present it like an acute GBS like presentation. But because once we make something of a diagnosis like that, then if it doesn't respond, will you consider giving it's a very controversial question. Will you consider giving rituximab in such a scenario or not? So if you not respond to IVIG or I'm saying it's a particular scenario where it's even in the DBS criteria, the red flags of rapid progression within 24 hours is a red flag. So a patient gone into the ventilator in a matter of few hours or within 24 hours and is not responding to any of your treatment, IVIG or placebos. Would you consider doing paranodopathy or you're satisfied with diagnosis of GBS?
It's a loaded question, and I expect nothing less from you. So it's a question which has got a lot of clinical relevance. So at what point would you order this test? First of all, as far as I am aware, I don't think we have these contacting and neuroefficient antibodies available in our country. So it's still a research tool. So that question, that sort of makes things easier. There's no way you can test for these antibodies. Secondly, I would still start off by doing starting the patient with on first line treatment like IVIG or plasma exchange. If, as you told, if after the first or second week, after the course of IVIG, and even after 1 to 2 weeks, you don't see any improvement, probably at that point of time, you may think of paraneuropathy, but by the time it may slightly later, you may have lost that margin of opportunity. So I don't really have an answer for you. So, but because we don't want to start a trend of treating GBS or rituximab, I would reserve my comments. But I think that's a very important question. I don't really have an answer. But what I would do in my practice, I would still continue the first line treatment of IVIG and plasma exchange. And if the patient has no other improvement, and then there is this option of treating with rituximab. But when to give it, how to give it, we still don't know. Especially since we don't have the antibodies to go check.
Yeah, just to describe that, is the whole theater runs on the nodes. So ultimately, we still need to know a lot of things on the node at where what happens at the point of time.
Can I turn the question around? What would you suggest?
What will you? I mean, I have given to one patient, so that is why I have told. And that patient improved, but I mean, if we could have improved its natural history also. So we don't know whether that improved or whether that made a difference or not. I can't completely say that it's because of that. Because of that. So I mean, my threshold for giving such a treatment is I have only one threshold. If its patient is on ventilator on day 1, that means onset to ventilator time is less than 24 hours. Then I have and if they don't respond to both treatment, because I'm not given rituximab on day 1 or day 2. I'm not saying that day 1 or day 2. If you are not usually our protocol is always plasma exchange first. So our first plasma exchange, then followed. If it doesn't respond, then we'll go to IVIG. If both the things are done, you still can't take out of ventilator. The patient is not on the ventilator, or patient is having severe weakness. It's worth trying a shot. That's all my point. But I don't vouch for the improvement.
Neither do I. I also wouldn't treat with rituximab, at least in the initial stages. Yes.
Okay. The other question is how to differentiate between primary demyelination with secondary axonal versus, I don't know, one more line. So basically, I think he's decided with the primary demyelination with secondary axonal changes or mixed demyelination. Probably if you wanted to know something like that.
Probably you can set up a session on electrophysiology, and we can talk on that for hours. So it's a very difficult proposition. Sometimes it's not easy. The only point to note is that if you have to diagnose an axonal entity, there should not be any demyelinating features. If there is any demyelinating features, then it will be an AIDP. So if you to diagnose an AMAN, the finding should only be axonal. So that may be one thing. Second thing, always try to do up a follow-up study. So many of the things which are not there initially may show up, and then you may have a clear picture. So that will be the simplest answer to the question.
Yeah, even in our GBS consortium, we were looking for thing at start and do the repeat as NCS at the nadir point. If the patient has progressed at the nadir, also we do NCS and see. And another question was, is it axonal variety?
Can I ask one question here? Is it mandatory always to repeat the study when you are electrodiagnostics test?
Sir, in my opinion, it's not. I wouldn't say it's mandatory, but if the picture is not clear, you make it.
Okay, in that situation, you can understand it. And when conductions are plus minus then you can repeat it. But when they are classical, I don't think we need to repeat.
Yes, sir. If you can't classify it as a particular thing, just for a classification point of view, if you can't classify in the initial itself, then repeat and clear it off.
Okay, that's
the point I also made. Yes, sir. I agree, sir.
Why I'm asking it, there is improvement. You must have read the paper. Mishra did one study, and he says that conduction study follow-up should be done routinely. They do it routinely. He has written a paper, I think it published in JNNP.
Rarely there are situations where we have not even done a single study also. Sometimes patient go in the ventilator and there is no way we can do the conduction. And there are situations where we are treated.
In Nemon's, there should be portable machine. Neman should effort to have a portable machine. We have a portable machine in our ICU.
May not be possible in all cases. So NCS will help you a long way, but sometimes we cannot delay treatment just for NCS.
So next one is if every nerve is non-stimulable, how will you comment as axonal or demyelinating?
Beautiful question. So if the nerve is not stimulatable, we cannot say it's demyelinating or axonal. It can either be demyelinating or axonal. So both demyelinating pathology, if it is severe enough, can cause a non-stimulable nerve. In that case, probably EMG may help, but may not be, because if it's a AIDP, as it advances, eventually you're going to have an axonal pathology also. So initially, if the on paper, probably in the first 2 weeks or so, first few weeks, a patient has completely unstimulatable nerve, and you do the EMG, and the EMG is normal or only showing scanty evidence of denervation, probably we are dealing with the demyelinating entity. So, but if the nerve is completely unstimulable, we cannot say for sure if it's a demyelination or axon.
Yeah, do you think a blink will help if the patient has a bilateral facial?
It depends. So, as you know, it's like probably the facial nerve is the last to be involved because it's the shortest nerve. So, at that point, yeah, blink or a facial conduction may also help.
So, Vishnu, if I may add a point,
Yes, madam. Please.
So, I think that what you told is correct. You can do either facial conduction or even proximal upper limb studies. If there is a marked prolongation of latency, especially in CMT, this is more useful in CMT compared to AIDP.
Sometimes the speed, increasing the speed is also, for example, the distal latency is quite prolonged. We may miss it. So you can, by changing the speed.
I was mentioning about the sweep speed, especially when the F waves are not elicitable. Sometimes you can change the sweep speed. You may find an F wave which is very far out. So sometimes playing a lot of the sweep speed can also help.
Yeah, the latency may have been so prolonged that it will miss it. You may totally miss it. A lot of questions on CIDP now. So how will you suspect DATs? So essentially saying that probably in the realm of distal symmetric sensory motor polyneuropathy, the other garden variety that you usually see. In that scenario, how will you suspect DATs?
The prototype picture of a DATs is, like I mentioned, when we talk about a middle to elderly gentleman presenting with a long-standing process or a chronic, very insidious, slowly progressive entity where the patient has predominantly sensory symptoms, but without much of a motor complaint, but having significantly and predominantly early gait ataxia and tremor. So that is sort of like the prototype of a DATs. So initially, a sensory motor polyneuropathy, we may not get this pattern. And then on examination, the predominant pathophysiological finding will be demyelination, and you can always look for a terminal latency index. So when a patient walks to my clinic with a 60-70-year-old gentleman with a very slowly progressive course, predominantly sensory, significant sensory ataxia and upper limb tremor, that is when I think of DATs.
So majority of patients with CIDP can't afford monthly IVIG. So which oral autoimmune sparing agent you prefer, and what is the role of rituximab in your practice?
Absolutely correct. So first line of treatment of CIDP would be IVIG or steroid. IVIG, obviously, abroad there are many centers, they give monthly IVIG pulse, and they also give subcutaneous IVIG also, which is equally effective. But obviously these are not options in our country. So steroid would still be the first line of treatment. And steroid sparing agents, including azathioprine, mycophenolate, and cyclosporine, and methotrexate, all have been used to various degrees of improvement. Rituximab is also coming up in a big way. The threshold for giving rituximab is getting less and less day by day, actually. And if the patient does not respond to these first-line agents, and even after 6 months of treatment, you don't feel a significant improvement, probably that may be a good time to start rituximab.
So my practice of treating in CIDP and inflammatory myopathies are almost the same, except the threshold for rituximab in inflammatory myopathy in a drug refractory inflammatory myopathy is pretty clear. Well, in CIDP, which we are still not clear. That's one thing. Second thing is, how do you treat diabetes-related CIDP? $1 million question.
Yeah, they're all very excellent questions. So the entity of CADP and diabetes has always been a point of debate. But the final word of the jury is that there is definitely such an entity called CADP-DM. It is difficult to diagnose, even more difficult to treat, because the conduction can always, there is always this coloring by the diabetes over CADP, so you may not get a clear demarcating picture. The protein may also be high in diabetes also. So it's a bit tricky to diagnose, and treatment again would be the CADP treatment of CADP in a patient with diabetes would always be same. But obviously the thing is that diabetes steroid obviously would have a lot of side effects. So you maybe institute the steroid sparing agent earlier in the treatment. Otherwise, the treatment would almost be the same. Even ultrasound can have thickening in the case of diabetic neuropathy. Even MRI can rarely. So maybe MRI is one investigation which can help in this case, because the proximal roots may not be thickened in the case of diabetic neuropathy, but ultrasound distally can even show thickening. So
But,
yes, sir. Yes,
can
sir.
can I add one thing? By and large, any severe motor weakness in diabetic is not diabetic related. That is the dictum. So when you have severe motor weakness, we should consider possibility of ADP if it is acute and CADP. So by and large, severe motor weakness is not a feature of diabetic neuropathy. Except that acute, there is one entity, acute myositis type of picture, except that.
Can you hear? Hello, can you hear me?
Yeah, Vishnu, you're audible.
We are able to hear you.
Yes. So you have significant motor weakness, or if you have a predominantly proximal weakness out of proportion to distal or equal to distal weakness, in that entity, and supporting criteria of MRI showing root enhancement and thickened enhancement, or the CSF showing albumin-cycle dissociation, all these things will help along with the significant motor weakness in diabetic neuropathy. Then, how will you approach and treat diabetic symmetrical lumbosacral radiculoplexor neuropathy? Steroids or IVIG? What is your first line treatment?
It's all based on the assumption that there is an immune-mediated component. So biopsy shows that there is an element of vasculitis. So I don't know, as far as my last review, there is no solid evidence to treat with any immunomodulated treatment. But we have treated with cyclophosphamide, IVIG, steroid, and all that. So to go by an evidence-based guideline, I don't think we have an evidence-based guideline. So here there are people are using cyclophosphamide or plastic exchange also in certain cases, IVIG even. But I don't know which to choose, because steroids obviously can worsen the diabetes situation. So without an evidence base, it's difficult to venture such hazardous guesses.
Now, without an RCT, we are never going to answer the question. Patients anyway, at some point or some patients have a natural history of some amount of improvement, if not the full improvement dose. So, modality is IVIG.
There is one trial, not an RCT, a trial on giving weekly IVMP for about 12 weeks on the reducing doses. Start with 1 gram and then come down to 250 milligram weekly. I have found that almost invariably the diabetes status worsens, but patients eventually have a good outcome. So if the diabetes status tends to worsen, I suppose we can go for IVIG. And cyclophosphamide I have not used so much, but I've heard that people respond well, even with a single dose of cyclophosphamide, but again, no studies available for that.
My experience with steroids is good. We have few cases where one judge was severe. He could not sit for a minute in the court. So he responded very well with the steroids.
And this is a good area for a multi-center RCT, at least in our setting, which we can easily do. And I'm 100% sure if you don't achieve the primary outcome, at least safety outcome, we will know the answer. So the steroids in this one. So it's a good area.
You're mute, Vishnu.
Oh, sorry. So for another question was the Church-Stroke syndrome with mononeuritis multiplex didn't respond to methylprednisolone. So would you recommend cyclophosphamide or IVIG plus cyclophosphamide alone? What's the dose of cyclophosphamide?
I think that for ANCA-associated vasculitis, I think you should go for cyclophosphamide or rituximab along with steroid. I'm sorry,
yeah, true. I mean, for systemic vasculitis, it's pretty much clear for treatment of this one. Only our isolated PNS vasculitis, we are in the dark. Otherwise, systemic vasculitis, rheumatologists have given us clear the guideline for how to treat. So I think we'll, the rest of the questions, I think Deepak can answer directly on the chat box. So we are running out of time. So the next lectures, can I have a CV of Alex Rose?